There we go. Everybody can say that they're still okay watching now that they're being recorded. Ready. I'm going to talk about wrist and hand injuries today. So we're going to have a lot of visualization just because all these things take a little bit of picturing in your brain with the injuries and everything like that. But we'll get through it. Objectives: review the anatomy of the wrist and hand, review common fractures, review dislocations, review instability issues, and then review common musculotendinous injuries of the wrist and hand. So talking about the hand, the wrist, that's made up of the radius, ulna, and 8 carpal bones. I'm sure everybody has their own mnemonic to remember the carpal bones, but those consist of the scaphoid, the lunate, the triquetrum, the pisiform is how I pronounce it, but I've heard it other ways. Trapezium, trapezoid, capitate, and hamate. The DRUJ, that's the distal radial ulnar joint, allows for pronation and supination, so it needs some extra support and stability for that. You get that from the TFCC, triangular fibrocartilage complex, the extensor carpi ulnaris, the interosseous ligament, the pronator quadratus, and other muscles of the forearm per fin off. So I imagine everything in there just kind of helps stabilize. The radial portion of the DRUJ articulates with the carpal bones. And then the radius handles about 75 to 80% of the axial load through the wrist. So I kind of think of it as like the tibia and the fibula compared with radius and ulna. All right, the anatomy of the TFCC, so it's divided into a couple portions. There's the central articular disc portion. This portion's relatively avascular. So you can imagine what that would mean for healing processes. The dorsal and palmar radio-ulnar ligaments are vascular. Nice picture to the right here, but there's the volar ulnar ligament consists of the periphery of the TFCC, and the ulnar styloid, or connects the periphery of the TFCC to the ulnar styloid, to the lunate and the triquetrum. The ulnar extensor muscle subsheath and the ulnar collateral ligament of the wrist complete the TFCC. Something that'll be important later, but the TFCC is thinner in ulnar positive wrists. Thus, it can increase the risk for injury. So if there's a neutral ulnar variance, then the radius and ulna are the same length. If there's a positive ulnar variance, then the ulna is longer than the radius. And then you can imagine the negative ulnar variance is shorter than the radius. Anatomy of the carpal tunnel. I know Dr. Flannery had talked about neuropathic issues, so I won't harp on that, but just to show you the anatomy here. Anteriorly, there's a transverse carpal ligament, runs from the hamate to the pisiform medially to the scaphoid and trapezium laterally. And then the posterior portion is the carpal bones. The median nerve is in there, the flexor digitorum superficialis, the flexor digitorum profundus, and then the flexor pollicis longus all run through the carpal tunnel. And then on the other side, there's Guyan's canal. This is consistent of the volar carpal ligament at the roof, the transverse carpal ligament at the floor. The radial border is the hook of the hamate, and the medial border is the pisiform bone and the pisohamate ligament. And then innervation-wise, the radial nerve, that does sensation to the dorsum of the first two third digits in the radial half of the fourth digit. But there's no motor sensation from the radial nerve. The median nerve, innervation to the thenar eminence and the palmar aspect of the first and the third digits in the radial half of the fourth. This is the symptoms of carpal tunnel, and then motor to the first and second lumbricals and thenar muscles. I'm sure these are flashbacks to anatomy for some of you. And then ulnar nerve, sensation to the fifth digit in the ulnar half of the fourth, and then motor to the third and fourth lumbricals, palmar and dorsal interosseous, the hypothenar muscles, and then the thenar, one of the thenar muscles, the deep portion of the flexor pollicis brevis and the adductor pollicis. In the dorsal wrist, there's 6 compartments. The first is the APL and the EPB. Next is the extensor carpi radialis longus and brevis. The third, which is separated by the second by Lister's tubercle, is the extensor pollicis longus. I kind of try and remember it as longus brevis, longus brevis, longus. Might help, it might not. We'll see. The fourth compartment is the extensor indicis and the extensor digitorum, and then the fifth is the extensor digiti minimi, and the sixth is the extensor carpi ulnaris. So let's start with some fractures. Most common fracture in the wrist is the distal radial, or the fracture of the distal radius. Typically occurs with a fouche. One of the main things you want to look at is if they're unstable. So a positive DRUJ shuck test can signal some instability there. Workup, we do this all the time, but getting a 3-view x-ray to take a look at that joint. And on the right, you can see fracture of the radius. It's more of a torus fracture, but still a distal radius fracture. Non-surgically, we can treat these if there's no displaced extra-articular fragments. We put them in a they said long arm cast and neutral or supinated for 4 to 6 weeks. I've seen these in the short arm cast too. So seems like a little bit of a dealer's choice there. Surgical considerations would be displacement, comminuted, intra-articular, and then some angulations of the radius. So inclination less than 15 degrees, dorsal tilt greater than 20, volar tilt greater than 30, and then articular step off greater than 2 millimeters. Of course, if you have an open fracture, there's neurovascular compromise. That's a big deal and needs urgent surgical management. Here's some of those angles, which I'm sure everybody will remember by the end of this, right? So you have the radial inclination on the left, kind of shows you how to measure that. And then the volar tilt on the right shows you how to measure that in reference to the radius. The next is a scaphoid fracture. This is the most commonly injured carpal bone. Again, typically a fouche. It's the second most common fracture in athletes behind the distal radius fracture. Common ages are 15 to 30 years old. The most sensitive finding on physical exam is tenderness palpation over the anatomic snuff box. And I think I've learned quite a bit this year that, if you do that, we're going to treat them as a scaphoid fracture. The radiograph evaluation, you want the 4-view because you want that scaphoid view. And then if there's a high suspicion after negative x-rays, put them in a thumb spica, bring them back in 2 weeks and re-image. You can do CTs, MRIs, or bone scans to confirm if you need to earlier. You can see the different types of scaphoid fractures on the right, and we'll kind of get to what is a problem with those. Treatment. Unstable fractures require treatment with surgical fixation. Those include 1 millimeter of displacement, so not a whole lot of displacement, and you can consider surgical fixation. Malangulation, carpal instability. Stable fractures you can treat with a long or short arm cast with thumb spica. 90 to 100% of the time, within 8 to 12 weeks, these heal. They can be treated surgically to allow athletes to return earlier with a cast, which I found interesting. If you're a high-level athlete and need to get back, I guess that makes sense. The vascular concerns, this is the big reason why we take these so seriously. The proximal portion has a worse prognosis if it has a fracture than the distal. This is because of the retrograde vasculature. It goes from distal to proximal, so a proximal fracture has an increased risk of avascular necrosis. Why we take these so seriously. Next, the hook of the hamate fracture. You can see these commonly in golfers, baseball players, hockey players, those stick sports or club sports, or golf club sports. They typically present with pain over the volar ulnar portion of the hand. They have pain with grip. As you can imagine, if you're gripping something and putting pressure through that fracture, it would hurt. On physical exam, they have full range of motion. They just have tenderness palpation over the hook of a hamate. Radiographs may be negative, and they mentioned that CT is the gold standard to evaluate these. Management, again, can be non-operative. You can surgically fixate these, but sometimes they just pull it out and then they do okay with that. Next, metacarpal fractures. So one of the big things when looking at these is looking for shortening of the MCP with flexion. You can tolerate up to 5 millimeters of shortening. With these, evaluate the ulnar, or the radial and ulnar malalignment and extension. So make sure everything looks okay. Or angulation, I'm sorry, and extension. Overlap of fingers or rotation of the nail bed indicates malrotation. And then looking at these with PA lateral and oblique radiographs. The shaft fracture, a transverse fracture, is the most common. These typically occur when falling on a closed fist. Unstable fractures will tend to angulate with the apex directed dorsally. This is due to the volar pull of the interosseous muscles. So the end of the finger points dorsally. For these, different fingers have different rules, but you want to reduce if it's greater than 10 degrees for the index and long finger, greater than 20 degrees for the ring finger, and then greater than 30 degrees for the small finger. Oblique and spiral fracture of the metacarpal shaft. These are high risk because they commonly rotate or shorten. This is typically falling on an outstretched hand with a twisting mechanism. Again, non-surgical would be non-displaced fractures. And then surgical with any rotation, greater than 5 millimeters of shortening. Though I was reading, it seems like some places say that less than 2 millimeters of shortening, and they would surgically fixate. And then comminution would be another reason to treat these surgically. A neck fracture or boxer's fracture, the fifth metacarpal, that's the one I have here on the right. That often presents with dorsal angulation. And if it's angulated greater than 40 degrees for the ring or small finger, you need to have surgical consultation, and then greater than 10 for the index and long. So those are the dorsal angulation for these neck fractures. Next, thumb metacarpal fracture. So there's a couple special ones here. There's the Bennett fracture. This is an interarticular non-comminuted fracture at the base of the thumb. They generally like to treat these with ORIF because there's just a huge risk for post-traumatic arthritis. The next one is kind of just the next step up, the Rolando fracture. These are comminuted interarticular fractures. And of course, they have a worse prognosis because there's more fracture pieces. And again, these are fixed with or treated with fixation. The metacarpal base fractures are rare, and kind of management varies based on that. So you can see the Bennett on the first one on the left with the picture, and then the Rolando on the right. Phalange fractures. So these can be associated with tendon injuries. So that's one of the big things you need to look out for. This is going to take some visualization here for you guys, but due to the extensor mechanism and the dorsal translation of the lateral bands, a proximal phalanx fracture will tend to angulate with the apex going volar. Due to the FDS insertion at the medial phalanx, a proximal fracture of the medial phalanx will angulate dorsally with the apex dorsally. A distal fracture of the medial phalanx will angulate with the apex volarly. And then fractures of the distal phalanx lie between the insertion of the extensor. Fractures of the distal phalanx that lie between the insertion of the extensor flexor tendons will frequently be unstable. Things to look out for there. All right, we're going to move on to dislocations. So first, DRUJ dislocations. This is typically a fall on a pronated arm or a fouche on a pronated arm. We do get plain radiographs to look for fractures. If there's no fracture, we can do treatment with closed reduction and mobilization for 6 weeks. And the one thing I learned is you want these patients supinated. That's a big deal for them. And sometimes they don't necessarily tolerate it. So trying to get them as supinated as possible. Since we saw a couple of these at least I think 2. Yeah, we saw 2 in the clinic this year, and one was okay being supinated, and one we had to bring back a week later. to supinate them. There's an inability to reduce. If there's an inability to reduce, this should prompt that you check for soft tissue lodged in the joint. The main culprit is the extensor carpi ulnaris. Righty. Next, lunate and perilunate dislocation. So this is a result of excessive radiocarpal hyperextension, ulnar deviation, plus intercarpal supination. We have some pictures to the right to kind of help you visualize, but it's frequently complicated by compression of the median nerve. If you can imagine, we talked about that earlier and where the median nerve lies. So a lunate dislocation can press on that median nerve, lunate or perilunate. The diagnosis is typically made based on lateral radiographs, as you can imagine, based on the pictures. Perilunate dislocation, the capitate is dorsally displaced on the lunate, and a volar lunate dislocation, the lunate is displaced into the carpal tunnel. So metacarpal phalangeal dislocations, dorsal dislocation of the MCP joint is uncommon, but that's the most likely one to occur, or it's most likely to occur in the index finger. Sometimes these are referred to as irreducible dislocations due to the MCP getting caught on the musculature in the area. I did see one of these in my hand rotation where the guy was a high velocity motorbike accident, and they weren't able to do it in the ER or reduce it in the ER, so they took him to surgery later that week, but he had a 4th and 5th MCP dislocation. There's a high suspicion when there's hyperflexion of the MCP joint with ulnar deviation. Of course, radiographs are needed to assess for fracture. And then after you reduce them, you want them in a splint for 5 to 6 weeks, allowing for flexion, but you want to stop extension 30 degrees short of full extension. Coronal plane dislocations and volar dislocations are rare. Coronal is treated with closed reduction, and volar will require open surgery most of the time. All right, a PIP dislocation, also known as a coach's finger or jam finger. Most common ligamentous injury, sorry about that, of the hand. Common in contact sports that involve catching a ball, football receivers, basketball, things like that. Dorsal dislocations are the most common. Typically, collateral ligaments are injured when this happens. Again, radiographs are needed to see if there's a fracture. And the treatment depends on the stability. So if they're stable, they can do buddy tape. If they're unstable, there's typically an interarticular fracture. And we want to make sure that it doesn't involve 40% or more of the joint surface. That's the big number for these. And then again, you treat that with an extension block splint. If it's unsuccessful, you do surgical intervention. A volar dislocation typically requires surgical reduction associated with an injury of the central slip tendon of the extensor mechanism. So if you don't treat these, then they can end, well, they're treated like a boot in your finger. All right, PIP dislocation. Again, contact sports, handball was a big one here too. Again, those ball sports, usually goes dorsally. You can get a volar skin laceration on these. And then collateral injury is typically uncommon in these. You want to make sure there's no avulsion fracture, and then reductions achieved with traction, flexion of the joint. You want to splint these for 3 weeks. Going back to the laceration discussion here, I did have a patient I saw in the ED during my family med training who had it was a thumb dislocation, but she thought it was just a laceration, but it was actually an open dislocation. So when somebody has a laceration and then they say their thumb felt like they went out of place, it's just something to keep in mind. Anybody have any questions or anything? I'm kind of flying through this. We good? Okay, we'll continue on. Instability. So these are the ones that I had trouble kind of visualizing, but after, trying to write this up, I think it got a little easier. So the most common wrist ligament injury is the scapholunate instability. It occurs with excessive wrist extension and ulnar deviation with intercarpal supination, falling on a pronated hand. Wrist ROM or wrist range of motion and load bearing can be compromised due to the shearing of the articular cartilage with these, and then just the irritation, the synovitis. They get painful with Watson's sign, or they have Watson's. The scaphoid shift test or Watson's sign is painful. Radiographs of the bilateral wrist may be needed for comparison. So AP and pronated clenched fist. They have positive widening of 3 millimeters. The lateral, you talk about the scapholunate angle degrees, 30 to 60 is normal, increased above 70 is abnormal. Acute treatment for these, you want to do open surgical treatment if it's within 3 to 4 weeks, and then chronic, so 3 or 4 months or 3 months or greater. Surgical repair may be performed with anatomic reduction. If you can't do this, then they may end up needing a partial wrist arthrodesis, which is not great. Lunotriquetral instability. So this is less common than the previous one, caused by axial load with the wrist extended and radially deviated. These present with ulnar-sided wrist pain, and it's worse with ulnar deviation. You get the positive lunotriquetral shear test, which I don't know if I've done a whole lot of those this year. And then radiographs are typically normal. An MR arthrogram might show this, but the arthroscopy is the gold standard for this and might be needed in these particular patients. Again, you can do immobilization with or without steroids, but these might need surgery if they're refractory. All right, one of the ones I think we commonly see is the first MCP of UCL injury. So these are typically due to hyperabduction and radial deviation of the thumb. And then you get tenderness over that UCL. The big thing to look for is if there's a Stenner lesion. This is basically an avulsion fracture of the UCL poles and creates an avulsion fracture. These are pretty common, so we got to keep an eye on these. They're typically treated with open repair if you were going to repair them. But I've seen some that were treated just without the Stenner lesion, or we'll get to that, I guess. Imaging, AP and lateral to assess for a fracture, of course, and then MRI if you want to grade it. If they're stable, they don't have a Stenner lesion, thumb spica 4 weeks, and then followed up by 2 to 4 months with the removable splint, especially if they're doing contact. And then surgically, if they're unstable, Stenner lesion, large displacement.
Projection segment comes from Morgan. I don't know what ever happened before.
How did I get wrong?
Okay. Just somebody's. Okay. All right. We'll move on. Thought somebody had a question. So musculotendinous injuries, dequervating tenosynovitis. I think most of us have seen this year, but it's tenosynovitis of the first dorsal compartment. Most common tenosynovitis, just repeat movement of the APL and the EPB in that first compartment, if you remember, longest breaths. Common in golf, fly fishing, racket sports, those that require a force grip with ulnar deviation, if you can imagine force grip and then deviating that ulnar, pulling on that first compartment. Presentation, they have pain over the radial aspect of the wrist with palpation, positive Finkelstein's test, treat with immobilization, arrest. We can do steroids for these, and then you can refer them to ortho hand if these are continue to be refractory. Intersection syndrome. So there's 2 separate types of this. The most common is the proximal intersection syndrome. This is the first extensor compartment crossing over the second extensor compartment. And it's located at the crossing that first, the APL and the EPB. Frequently seen in sports, not with repetitive wrist extension, rowing, weightlifting, and racket sports. The distal intersection syndrome is a little bit more rare, but that's the third over the second. So the proximal, or the first one you get to is the first over second, and the distal, or the second one you get to, is the third over the second. And so treatment includes rest, splinting, and NSAIDs. If refractory, you can do steroid injections, but it's something to keep in mind.
Hey, Tyler, it's Suze. Can you hear me?
Yeah.
So those kids, the other classic thing about them is in the more common type, they squeak. So like I had a kid come through the door literally 1 week after I did my last recert, and he was a tennis player, and literally whenever he went his wrist up and down, it was like e. A lot of times it can be like an audible noise with intersection syndrome. So and it's just literally the rubbing of the crossing of the compartments. So with the inflammation, so it's also a good diagnostic thing to know. And they may mention that on CAQ is the audible noise.
Oh, that's really cool. I didn't know that. Neat. Thank you.
Not a common problem.
Yeah, but something that's unique for that specifically. Cool. All righty. Next, jersey finger. This is something I don't know if anybody's ever seen this year, but FDP avulsion. So it's typically the distal phalanx. And the mechanism is when somebody's going to grab a jersey and the finger is forced into extension while the dip is flexing and trying to grasp. Most commonly at the ring finger, 75%. So they have the inability to flex that dip actively and tenderness over the site where the avulsion occurred. Radiographs to assess for fracture. I'm getting redundant with that, but MRI or ultrasound can assess that the tendon is retracted. For surgical treatment, you want to get them done pretty quick, 7 to 10 days. Chronic cases typically are non-painful and functionality is minimally affected, so you can kind of watch, but you can see that picture on the right, and they just extend their dip, and they just can't flex it with a fist, which is kind of neat. Mallet finger. So this is due to the disruption of the terminal extensor tendon at the distal phalanx. Occurs typically by jamming a finger into a ball or another object. Common in baseball, basketball, and football. And then you have the inability to extend the dip. X-rays again for fracture. You treat these with splinting the dip and extension for 6 weeks, and then 4 weeks at night after. Consider surgery again for that that 40% of the joint surface we talked about earlier, and then volar subluxation of the distal phalanx. If you have that, consider surgery. If untreated, you can end up with a swan neck deformity. So good thing to keep in mind here. And then trigger finger, I saw a bunch of these on my hand rotation, but basically a nodule forms on the flexor tendon sheath. It gets trapped in that A1 pulley, and they have triggering of that finger or clicking of that finger. Steroids do pretty well with this. About 90% of cases are the symptoms improve with 90% of cases, but eventually if they have it again and again, they might need surgery to go in and remove that. Next, boutonniere finger. This is the rupture of the central slip of the extensor mechanism. It results from trauma to the dorsum of the pip, force flexion at the dip, and lateral or volar dislocation of the pip. Typically in basketball or volleyball players, you have the inability to extend a flexed pip, but you can hold it if it's passively put there. Treatment, if passive range of motion is full, splint the pip and extension for 6 weeks. Chronic cases, serocasting or splinting for prolonged duration. And if there's a avulsion fracture greater than 2 millimeters, you think about surgery for those. TFCC injury, these typically are from a fall on a pronated hand or hyperextended hand, overuse or repetitive trauma. Typical symptoms are tenderness over the TFCC region, pain when lifting with forearm and supination or pushing off the palm of the hand. Kids talk about push-up or having pain with push-ups or pain with getting up off the chair. Positive TFCC grind. X-rays may show ulnar variance, which we talked about a little bit earlier, with the positive ulnar variance being a higher risk for this. MRI 3T you need, or 3 Tesla for this you need to evaluate, or an arthrogram, because you're assessing that cartilage, and then arthroscopy is the gold standard. Neutral wrist splint for 4 to 6 weeks, and then surgically you can treat. These can be treated surgically with debridement for the central tendon, repair for the peripheral tendon. And then they do occasionally consider ulnar shortening, interestingly enough. So, just because of that positive variant. Radial epiphysitis or gymnast wrist is typically seen in young gymnasts with repetitive dorsiflexion. The X-ray may show the epiphyseal widening or metaphyseal irregularity. You can see the pictures of the widening there on the right. And then treatment would be activity modification, but good luck sometimes, or resisted hyperextension with splinting or taping. Nail bed injuries.
Can I pipe in for 1 second?
Please.
My other comment, like you said, good luck with activity modification.
Mhm.
Sometimes these kids just have to be casted because they can't shut down, and sometimes you just see a really bad, significant whining, lots of pain, and even if you exos them, they can be pretty non-compliant. So
Yeah.
I definitely have casted them before at times.
Interesting. That's good to know. I guess, if you're splinting, casting the splint, so that works well. Cool. Thank you. All righty. Next, nail bed injuries. So again, x-rays for fractures, subungual hematomas. These can be decompressed. This can be done with an 18 gauge needle or cautery. The rule, I believe Dr. McFarland had mentioned it to me, would be 50% of the nail. If it's covered up, they would benefit quite a bit from it, but you could do these pretty simply in the office, which is nice. Simple lacerations in the nail bed. You repair these by removing the nail plate to suture and then replacing the nail plate after, which sounds pretty painful. I imagine they give you some analgesic, and then complex lacerations, they often occur with a distal phalanx fracture. So again, x-rays, and then avulsion of the nail and nail complex injury with loss of nail bed, you can treat with surgical. Ganglion cysts, so these are synovial cysts, most common at the scapholunate space, also referred to as Bible cysts. If painful, they can lead to decreased range of motion. They can have swelling or not have swelling. Ultrasound can look at these, MRI can look at these, but treatment's basically observation. Can aspirate and do corticosteroids or surgical removal. They call them Bible cysts because the theory is people used to hit these with a big book and they burst, but then they come back. So sounds like the juice isn't worth the squeeze there. Flexor tendon laceration. So these are transections of the flexor tendons. These can happen anywhere at the wrist, hand, or finger. They typically present with a laceration in addition to the inability to flex their digits. Again, x-rays, but then treatment, you want to irrigate and skin closure, and these need to have surgery within 10 days. No real role for certain non-surgical treatment for these, or they'll just lose their ability to flex. So I did put some questions here at the end. So question 1, which of the following is a risk factor for a TFCC complex injury? And anybody can answer, but I can pick on Justin or Austin. Austin? Justin? Okay.
Yeah, was that owner positive variance with the
Yeah. Yep, you got it. So the ulnar positive variance, just a risk factor for these injuries. These occur when the ulna is longer than the radius. Right. And then 2, a dislocation to MCP most commonly results in which of the following abnormalities? Fuller dislocation of the MCP with ulnar deviation of the effective finger over the adjacent, a dorsal dislocation at the MCP with ulnar deviation of the affected finger, volar dislocation at the MCP with a radial deviation, a dorsal dislocation of the MCP with radial deviation. This one's a little bit harder. But he had a chance to think about their answer. So it's B. A dislocation at the MCP most commonly results in dorsal dislocation at the MCP joint with ulnar deviation, the affected finger, overlapping the adjacent finger. And then lastly, during a volleyball game, a player suffers an injury that is at risk of leading to a boutonniere deformity. If this player is examined shortly after an injury, which deficit would be present at the PIP? inability to extend the PIP from a flex position, inability to flex the PIP from an extended position, inability to maintain extension of the PIP if placed in a positive, if placed in this position passively, and inability to maintain flexion of the PIP if placed there passively. All right. And that's A. This is that Bittner, the central slip issue. If there's a, with the Bittner, they can't extend from a flex position. They can maintain the extended position if put there passively. However, yeah, so it's the big thing there. That's what I got so far. That's what I got. Any questions or any comments from anybody?
I know you mentioned a couple situations where you may have a laceration present with a dislocation. Typically, are you putting those people on Keflex for 10 days?
Yeah. So open fracture, I definitely do Keflex for those, just because we want to make sure that we protect them from infection.
Yeah. And then I would, the talk's great. Like, it's a lot of meat when you're talking about CAQ prep. If you go on and then end up giving this talk to residents whose learning level is obviously less than where we all are, probably just some pictures about like the specific tests, like the, like how to do Watson's, how to do TFCC grind. Like, I'd add in how to do like the specific tests if you're going to throw other learners into this talk down the road.
Okay, absolutely. Thank you.
Nice job.
Thank you.
All right. Nobody else has questions. All right, guys, we need to do our quarterly meetings at some point because we're going to